Dear colleagues, good afternoon. Today it's a special day, and this is because we have the great pleasure and the honor to have once again Professor Ippolito from Milan, Italy. You know him probably. He's an excellent speaker. He's one of the most important abdominal radiologists nowadays. He's regularly invited in SPR, DCR, in many places in the world to give his lectures because he is also an excellent speaker. So whatever I have to say about Professor Ippolito, it will be less than he deserved. So I will say nothing more. Thank you once again, David. And two topics today. Always he offers us two topics. The one topic is concerning the imaging protocols for after abdominal examination. And the second one is the imaging of liver ductal plate malformations. So thank you once again, and we are all ears.
Thank you so much. Beautiful words. For me, it's a great pleasure and honor to be here again. So thanks for inviting me again. Thank you to you and Professor Atsidakis. You are really great friend, more than colleague. And so, as usually, I try to give you two different speeches with different topics. One more dedicated to the protocol and technique, the other one to the clinical disease. And we can start with first. Yes, up to you if you prefer. Okay, we can start with the first presentation that is dedicated to the abdominal protocol, acquisition protocol. Wow. I can use it. Okay. Well, as we know, the abdominal CT scan are used to depict the organs, tissues, and vessels in the abdomen, and the indication for this examination is very important to decide which protocol should be used and whether if the examination deserves any contrast agent or not. And moreover, when we perform a CT scan with intravenous contrast agent, we should decide how many phases we deserve to perform at the best our CT examination. The contrast media are used to improve the visibility of internal organ and structures that could be helpful in differentiating between normal and pathological areas, like in this example of a patient with an important spleen laceration and with subcapsular hematoma. Without contrast agent, it is almost impossible to correctly categorize and define the kind of lesion the patient has. And the contrast media, it's able to increase radiology efficiency in terms of sensitivity. That means possibility to recognize the lesion in number and size due to the enhancement. Increase efficiency in terms of specificity. That means the possibility to characterize the lesion according to the different vascular behavior during the different vascular phases. And finally, it is really useful to evaluate vascular structures. But first, let me define what means sensitivity. Sensitivity means the possibility to increase the conspicuity of some findings that are already present. Like in this example, in which we are looking from the satellite, the north of America, but only if compare the images with the standard view, we are able to differentiate one of the huge blackout in the history that involve all of the area of New Jersey. So the conspicuity is really important, and only looking at the details and different contrast behavior, we can differentiate if a lesion is present or not. Well, the specificity means the possibility to differentiate lesion according to the different vascularization. And again, I would like to show you an example of two different patients with two different kinds of lesion, both in the same right lobe. In one case, we can appreciate a typical hypervascularization in arterial phase, followed by washout in the late phase, so in line with diagnosis of hepatocellular carcinoma. While in the second case, we can appreciate the progressive increase of vascularization of this surrounding lesion in line with hemangioma with progressive filling of the lesion. So before starting with our acquisition protocol, we should ask ourselves two different questions. The first one is, what are we looking for? And the second one, which phases do we need to obtain and observe it? And so we should first carefully study the history of the patient, because the patient history is mandatory. We should check if the patient already underwent previous abdominal CT scan. That can be really useful for comparison, because in most of cases we observe only one contrastographic phase and evaluate the evolution along of the time. But sometimes the patient may have a different history, may have different kind of vascular lesion, like the hypervascular metastasis or hypovascular one. And so it is important for us to choose how many contrastographic phase we should have to acquire. And finally, also the clinical status and previous history are important, because in some cases, the patient already undergo abdominal surgery, radiotherapy, chemoembolization, and so on. And the history is mandatory to decide the correct acquisition protocol. And from clinical point of view, usually we have several possibilities regarding the contrastographic phase. We have the early arterial phase. That means the contrast is still only in the arteries, and we have no enhancement of organs and tissues. We can take the advantage of late arterial phase. That means that all of the structures that are characterized by important blood supply may hyperenhance. The spleen usually is inhomogeneous, and we can also appreciate the contrast agent inside the blood vessel. While in the portal venous phase, the liver parenchyma enhance at its best, mainly to the dual blood supply that is supported mainly by portal vein. And usually in the portal venous phase, we have an isodensity of the entire spleen. Moreover, we can have the nephrogenic phase. That means that the entire renal parenchyma, including the cortex and medulla, enhance in the same way. And finally, we have the delayed phase that is really useful to evaluate the fibrotic tissues. And in this first contrastographic phase, we have a part of opacification of the urinary tract. So let's start with an enhanced CT scan, and we should know what we can look at without contrast agent. In emergency setting, I think the unenhanced CT scan, it is really important because it allows us to recognize several entities. First one is represented by the fat stranding that is really useful in highlight where that disease are located inside the abdomen. It is really useful also to recognize fat in the liver tumors, like in case of metaplasia of HCC, or to recognize the fat in the adrenals, typical of adenoma lesion, or we know that it's really common today to recognize the liver steatosis, that means accumulation of fat inside the liver. And obviously, the unenhanced CT scan is mandatory to recognize calcification that can be typical for several diseases like echinococcosis, stones, and so on. And so the calcification may be located in different organs. Finally, the unenhanced CT scan is mandatory also to characterize the fluid abdominal collection, because it allows us to distinguish between the pure fluid content and hemorrhagic content. And let me show some example. With an enhanced CT scan, we can be able to recognize stones in the gallbladder, in the first tract of the urinary tract, or we can recognize this calcified cystic lesion in line with echinococcus localization, or in this case, we can recognize some stones due to an amoebic infection of the right liver lobe. And one of the most important signs that I love when I work in the emergency department is the fat stranding, because the fat stranding, that is an hyper attenuation of the fat, is really useful to recognize the localization of different diseases. If you are in front of bowel ischemia, bowel perforation, gallbladder cholecystitis, or like in this case, in which you are in front of omental infarction, that is a typical cause of abdominal pain in our emergency department, characterized by halo sign. And the different attenuation between fat and omental infarction or fat stranding, it is really useful without contrast agent. Another great thing, typical disease is represented by liver steatosis. that is characterized by lower homogeneous attenuation of liver if compared with spleen, at least 10 or 12 ounce-filled unitlets, and maybe can be more evident when we administer the contrast agent. Finally, it is mandatory to perform the unenhanced CT scan in those cases in which we would like to recognize the content of fluid alteration, like the pure liquid cyst, both in liver or in kidney, or in those cases in which the patient presents an hyper-attenuating cystic lesion in the right kidney, in line with simple cyst with hemorrhagic component, or in this case of patient with hemorrhagic cholecystitis, and the gallbladder is full of hyper-attenuating fluid. What can we detect while in the next phase that is represented by arterial phase? Usually in this first phase, we are able to recognize some disease that can involve aorta or main arteries, like aneurysm, dissection, or can be really useful in the emergency setting to detect the arterial bleeding. And again, let me show an example of a patient with typical arterial dissection. In this case, the superior mesenteric artery was involved by the disease. We are able to recognize this hypoattenuating line inside the hepatic artery. While in the late arterial phase, we are able to recognize first the opacification of vessel, but we should know that some specific organ enhance at their best during the arterial phase, mainly stomach, bowel, pancreas, while spleen presents an inhomogeneous opacification due to the presence of stripes. And during the arterial phase, late arterial phase, we could be able to detect some lesions that are characterized by significant arterial supply, like hypervascular 1, hepatocellular carcinoma, hemangioma, neuroendocrine tumor. But in the arterial phase, we can recognize also hypervascular tumor inside the pancreas, like the neuroendocrine tumor. We could be able to recognize the ischemia of the bowel and some area of alteration inside the liver parenchyma. And again, let me show this case of a patient that presents several rounding hyperattenuating lesions in both of the lobe, in line with hypervascular metastasis from renal cancer. And this is another example of patient that present a neuroendocrine tumor that is localized in the distal tract of the bowel, associated with multiple neoplastic lymph nodes, and can be clearly recognizable during the arterial phase. While during the portal venous phase, we can appreciate an homogeneous opacification and attenuation of almost abdominal organs. That means that we have the possibility to recognize different diseases, like the hypovascular lesion inside the liver parenchyma, or in a different site, like in the bowel, in the ovarian area, in the cervix, and so on. We can also appreciate some disease that may involve the venous system, like the thrombosis or neoplastic thrombosis of the portal vein and the peripheral vein. And finally, we could be able also to recognize the typical pancreas adenocarcinoma. In this case, I'm showing you the typical rounding hypoattenuating lesion from colon cancer, again localized in the left liver lobe and the right liver lobe, characterized by an halo sign around the neoplastic lesion with solid enhancement inside. And this was another example of typical venous patency, in which we are able to recognize this huge thrombus inside the mesenteric vein that involves also the ileocolic vein along the left side of the abdomen. While during the nephrogenic phase, we can define this phase as that one in which the entire renal parenchyma is characterized by homogeneous opacification, because in most of the cases during the portal venous phase, we appreciate only enhancement of the cortex and not of medulla. But it's important to obtain an homogeneous opacification of both cortical and medulla in order to highlight any possible oncocytoma or renal cell carcinoma. And so should be performed a little bit late in order to better highlight the differences in terms of attenuation between the solid neoplastic lesion and surrounding renal parenchyma. Finally, in the delayed phase, what we can detect, for sure, the fibrotic or stromal tissues that are typical of some tumors like cholangiocarcinoma, or maybe we could be able to recognize the scar of some liver lesion like the FNH and fibrolamellar hepatocellular carcinoma. But during the delayed phase, we are able also to recognize the typical washout of hepatocellular carcinoma lesion with pseudocapsula that surround the neoplastic alteration. And here we are in front of two different patients. In this case, we are in front of a patient with HB infection, and we are recognizing the typical rounding washout of hepatocellular carcinoma, while in this case, we can recognize this inhomogeneous hyperattenuating lesion associated with dilation of the biliary tree in line with cholangiocarcinoma lesion. Okay, even if from a clinical point of view, we can take the advantage of different contrastographic phases, usually in the most of cases, we observe only 3 contrastographic phases after the unenhanced CT scan that are represented by the late arterial phase, because we are able to appreciate not only the lesion, but also the vascular structures, the portal venous phase that can be delayed a little bit in order to obtain an homogeneous opacification of the entire kidney parenchyma, and the late phase. In this way, we could be able to make the correct diagnosis for most of the lesion. And usually, this kind of protocol is quite typical to assess liver and biliary tree disease. We suggest an enhanced CT scan, arterial phase, that should be performed usually by using a Kerr bolus or bolus striking technique in order to obtain the same kind of opacification in all of the patients, portal venous phase and delayed phase, having an intermediate or high injection rate. And usually the contrast media dose should be related to the weight of patient. And let me show some cases. Let's start with the first one, in which we are recognizing a dysmorphic appearance of the liver, some free fluid on peritoneum, and we are recognizing this pure hypoattenuating cystic lesion with some focal calcification. If we perform the arterial phase, now we can immediately recognize a new lesion that is characterized by hypervascularization. While during the portal venous phase and during the delayed phase, we can appreciate the typical washout with pseudocapsule, so in line with hepatocellular carcinoma, while the other lesions still remain hypoattenuating in line with the simple cyst. Let's move to this other example. Again, we have a dysmorphic appearance of the right liver lobe. Again, we have some free fluid, and we can recognize this inhomogeneous hypoattenuating lesion that is characterized during the arterial phase by a targetoid appearance, so typical peripheral hyperenhancement due to the solid neoplastic component, while during the portal venous phase and during the delayed phase, we can appreciate the increase of opacification of the entire lesion in line with cholangiocarcinoma. Or in that case, again, we have the same appearance during the unenhanced CT scan, but if we look at the arterial phase, we can recognize several hot spots evident at the periphery of the lesion. We can appreciate the increase in dimension of the hot spot that continue during the delayed phase. So this is a typical progressive filling of hemangioma with blood pool content during the delayed phase. And again, another kind of hypoattenuating lesion with a rounding morphology in the right liver lobe that is characterized by halo sign during the arterial phase, while during the portal venous phase, we can recognize an hyper-enhancement of the capsule that still remain present during the delayed phase. And so in this case, we are in front of abscess that is characterized typically by rim enhancement that can be evident both during the arterial phase or during the portal venous phase. Well, do not forget, please, when we look at the liver imaging, that we can differentiate the vascular pattern of enhancement of the different metastases, because unfortunately, not all of the metastases are hypovascular inside the liver parenchyma, but we can be in front of different behavior during contrastographic phase. So it is important during follow-up of neoplastic patient to really know the patient history and the main tumor, because some of them, in particular melanoma lesion, thyroid carcinoma, breast carcinoma, hepatocellular carcinoma, renal cell carcinoma, neuroendocrine tumor, are characterized to offer hypervascular metastatic lesion that can be maybe recognizable only in the single arterial phase. Like in this example of patient that present several hypervascularized rounding lesions that are evident. Some of them are evident only in the arterial phase, but are not evident in portal venous phase, neither in the delayed phase. So recognizing the primary tumor is mandatory to make and to perform the correct acquisition protocol. And this is another example of different kind of tumor. In this case, during the unenhanced CT scan, we can recognize some tiny calcification inside the rounding lesion that are characterized by hypoattenuating during the different contrastographic phase. And do not forget that the calcification are quite typical of mucinous tumor producing, of a tumor that produces mucin, typically adenocarcinoma from colon or from rectum, and typically they do liver parenchyma metastasis or from ovarian cancer. But in case of ovarian cancer, usually the metastases are located in the capsule, and also in this case, we could observe some calcification. And usually also the bone tumors may create calcified metastasis, but they are really rare events. So we are able to characterize the different benign and malignant liver lesion according to their behavior during the different contrastographic phase. And these are summarizing graphs that show the main differences between the main benign and malignant ones. Let me move to the pancreas. When we look at the pancreas, usually we can take the advantage, again, to use a multiphasic approach. Usually we do not deserve any delayed phase, but the most important thing is to perform the so-called arterial pancreatic phase. That means delay a little bit our acquisition protocol, because pancreas is a gland and is characterized by significant hyperenhancement in order to produce and deliver hormone inside our body. And so the maximum enhancement could be obtained 40 seconds after the contrast venous injection or after 20 seconds after the care bolus technique. And obviously we should perform also the venous phase. Why it is so important to perform the late arterial phase? Because in most of the cases we can be in front to adenocarcinoma that typically is an hypoattenuating tumor due to its stromal nature. And so if we perform the arterial phase, it's more simple to appreciate the differences between normal pancreas and neoplastic pancreas, because in most of the cases in portal venous phase, the tumor may have the same attenuation of standard pancreas. Obviously, if the tumor is quite bigger and we have the necrosis, it's more simple to recognize it. But in the other case, especially for small tumor, it is mandatory to perform the late arterial phase or pancreatic phase. And in this case, we are able also to recognize the dilation of the Wirsung duct that increase our sensitivity and specificity in make the correct diagnosis. And the late arterial phase is also useful to recognize the typical neuroendocrine tumor of the pancreas that are characterized by hypervascularization, both in the arterial phase and in portal venous phase. So it is mandatory to have both sequences because the neoplastic lesion, the hypervascular neoplastic lesion, maintain the hypervascularity during the portal venous phase, while the behavior of cystic adenocarcinoma is a little bit different, and I'll show you an example later. Moreover, the pancreas can be the site of phlogistic alteration, like the pancreatitis. And so the patient may present a typical peripancreatic edema with the fat stranding. And it is important when we look at the pancreas also to perform the so-called carved MPR reconstruction in order to evaluate in one single image the entire gland And in this case, we are able to recognize the dilation of the bursting duct due to a small stones. But evaluating the entire parenchyma is more important, especially in those patients that present the necrotizing pancreatitis. In the necrotizing pancreatitis, we can appreciate first, during the unenhanced CT scan, a very high attenuation of the gland due to the hemorrhagic component, while during the arterial phase and during portal venous phase, we can recognize the significant differences in terms of vascularization between patency and normal gland. So from healthy and not healthy pancreatic parenchyma, and performing the MPR, we could be able also to quantify the necrotic component of the pancreatic gland. That is really important from a clinical point of view, because in case of more of the involvement, more than 50% of the pancreatic gland is at high risk for death of patient in the emergency setting. So we should quantify it in everyday clinical practice. And let me show another example of pancreatic cystic lesion. In this case, I'm showing a really huge polylobulated fluid content lesion that is characterized by hyperattenuation during arterial phase with a typical honeycombing in portal venous phase, and we can observe a sort of washout that it is also evident in these coronal reformatted images. Usually, the small pancreatic cystic lesions are characterized by hyperenhancement and are followed by washout, and they have to go in differential diagnosis with neuroendocrine tumor. Usually, the neuroendocrine tumor maintain hypervascularity in portal venous phase, while the cystic lesion wash out the contrast agent. And obviously, the MR is the most significant technique to recognize the fluid content microcystic alteration. Let's move to the spleen. Again, also when we work in the spleen domain, we should consider a multi-phase approach, and we deserve a standard arterial phase and portal venous phase. And we know that during the arterial phase, we have the typical vascularization of the spleen that is inhomogeneous with presence of a white stripe inside the parenchyma that become homogeneous during the portal venous phase. And the presence of these white stripes and hypervascularization, it is really useful to recognize a specific entity that is called intrapancreatic accessory spleen, that is quite common in everyday clinical practice, and is a benign alteration characterized by spleen cells that develop inside the pancreas. And usually, to make the correct diagnosis, we know that the IPAS may have the same identical behavior in all of the different contrastographic phases of the spleen. So we have to compare the lesion. While in case of a neuroendocrine tumor, the behavior is totally different, because again, the lesion is hyper-enhancing in arterial phase and still remain hypervascular in the portal venous phase. But in some cases, we can also appreciate a rounding, hypoattenuating solid component in line with spleen metastasis that can appear in those oncologic patients. And sometimes when we perform the abdominal CT scan, maybe for abdominal pain, we can recognize some strange, huge mass, like in this example, inside the stomach. We performed a multi-contrastographic phase in order to make the correct diagnosis. And if we look at these images with this target sign, we cannot appreciate any contrast enhancement. And I would like to show you a really beautiful case of Rapunzel syndrome, that is a specific disease in which the girl loves to eat her hair. And this is a huge mass of hair called also trichobezoar that can be recognized due to the inhomogeneous structures and absence of enhancement. Finally, we should highlight the last kind of protocol that we should use in normal clinical practice, that are represented by trauma protocol. In trauma patient, again, we should perform all of the contrastographic phase in order to recognize the different entities, blood, bleeding, lesion of kidney and of urinary bladder, and so, or lesion of the venous structure. So we deserve all of the contrastographic phase, and we have to acquire the entire abdomen. But before sharing some clinical case, I would like to offer you some tips to remember in the emergency setting, because the vascular lesions are quite frequent. And we have two different vascular lesions. We have the vascular injuries that can be represented by pseudoaneurysm or fistula. In this case, we have an hyperenhancement during the arterial phase that are characterized by decrease in attenuation on delayed images, and we can define as a wash away of contrast. And we could have another kind of alteration that is the typical active bleeding from lesion of some organs or from arteries, in which we have a fluid collection characterized by progressive increase both in size and in attenuation during the delayed phase. And let me show this example of a patient with typical parenchymal injuries that is characterized by this linear hypoattenuating area along the left lobe of the liver that reach the hilum. And so we should also remember the AAST classification in order to correctly characterize the level of trauma. In this case is a grade 4 because the lesion reached the hilum of the organ. This is another example of spleen lesion with an important blood hemorrhage along the subcapsular area. In this case, we have both the pseudoaneurysm and the bleeding along the capsule. And finally, this is another case in which the patient has a complete right lobe devascularization. We can appreciate the lesion along the arteries, the bleeding that still remain really hyperattenuating in the different contrastographic phase, but the MPR during portal venous phase in coronal plane allow us also to recognize the bleeding along the peritoneum that must be treated. And finally, before concluding the presentation, some tips how to perform correctly the CT scan. Obviously, at least with the CERVA 64 detector or more, we should acquire the entire abdomen from the diaphragm to pelvis. Usually, in most of centers, we suggest 100 kV setting with auto MIS exposure. But if you have the availability of the new algorithm, AI-based or model-based, you can reduce the kV setting to 100 or less, and usually we suggest a thickness no more than 2 millimeters to correctly stage the oncologic patient or to correctly recognize the bleeding and trauma in those cases of trauma patient. Finally, the total amount of contrast agent must be injected according to the shape of patient, and our radiographer must perform some additional reconstruction. Usually, we should look at the images also in the coronal and sagittal plane to obtain a beautiful overview of the entire abdomen and to having a better idea of the abdominal anatomy. And the MPR are mandatory in some specific oncologic condition, like patient with pancreatic cancer, in which we should measure the relationship between tumor and vascular structures, and we have to measure the contact angle of the tumor if compared with portal vein or with hepatic artery or mesenteric artery in order to correctly categorize the patient in borderline resectable, complete resectable, or unresectable. Moreover, in our clinical practice, usually we perform also the maximum intensity projection, both for the arterial phase and portal venous phase, to have a better evaluation of the entire portal vein tree or the artery trees, and can be really useful in some contexts, especially in those patients with hepatocellular carcinoma, because the MIP reconstruction may help us the interventional radiologist in order to avoiding wasting time and knowing which is the best way to reach and treat the neoplastic condition. And we have also the possibility to reconstruct the images in the opposite way by using the minimum intensity projection. And usually I suggest this reconstruction when we do not have the availability of MR, because are really useful to evaluate the biliary tree during the portal venous phase, and we can recognize the entire biliary tree and evaluating the relationship with cholangiocarcinoma for a better staging of the neoplastic lesion, or the minimum intensity projection may highlight also the air inside liver parenchyma, like in case of bowel ischemia or aeroportia. And this is an example of a patient with hilar cholangiocarcinoma, also known as Klaskin tumor. In this case, we can recognize the progressive enhancement of the neoplastic lesion. We can appreciate the dilation of biliary tree, the hypertrophic aspect of the left liver lobe, and on coronal plane, we can recognize the involvement of the portal vein, of the hepatic arteries, but using the minimum intensity projection, we can recognize that the lesion is still growing in the left biliary tree, but involves also the right biliary tree. So we are in front of Klaskin number 4 as classification, and the patient may deserve only oncological and chemoradiotherapy treatment and should not undergo through surgical approach. Finally, the MPR in coronal and sagittal plane may allow us also to immediately distinguish the normal vascularization of bowel wall or hypovascularization of bowel wall. And when we apply also the MIP reconstruction, we can appreciate this huge thrombus along the right side that cause a right side ischemia of the small bowel wall. So the combination of the different images, both axial plane, MPR, axial MIP, increase our confidence in making the correct diagnosis. And when we look at the images, we should look with soft tissue windowing that is really useful for solid organ, but do not forget, especially in emergency trauma, to change the windowing level and use the lung windowing and the bone windowing to correctly stage the neoplastic involvement for tumor, or to correctly recognize the air outside from bowel in case of trauma or in case of ischemia or perforation after tumor. And now I would like to thanks for the kind attention.
Thank you for your excellent work, because it was very, very didactic, in details and very practical. Because I think, and you will agree, that half of the diagnosis is the selection of the correct protocol. And not only the selection, but the performance of the correct protocol as well. You don't need to be a perfect radiologist, but you should know which protocol is appropriate, and you should supervise the examination in order to have the appropriate images in your hand. And then radiology is not that difficult. If you don't have it, don't have the correct protocol, things are okay.
It becomes more challenging. You need more strength to make the correct diagnosis.
Yes.
And it's the same also for cardiac imaging. My opinion, the perfect protocol is more simple to make the diagnosis, or also for MR. If you know what to do, you can save time.
And this is important for residents, because they are concentrating on imaging findings, not on protocols, or not. They don't care so much about being familiar with machines and train technicians as well, which is extremely important, because these guys have to apply all these protocols. So supervision of examination is extremely important. In younger radiologists, they do not do it because they think, because of lack of time and so on.
In our center, we have my residents have a rule. The first month they should stay with our radiographers, and they have to do the work of the radiographer. So first month for X-ray, then they move to CT scan, then MR, and angio. They should know how to manage a patient at least for 1 month, and then they could be able also to manage some side events that can occur during the acquisition, and they know how to manage correctly the patient. So it's mandatory for me, and also to have a good relationship with radiographers. They have to grow together, work together, and make the perfect protocol together. So it's a rule in our center. At the beginning, the residents are not so happy, but later, year by year, they understand the importance.
Absolutely. This is correct. And thank you for saying that.
They have it, but
It's important.
but it's an
I
advice.
hear from another. It's extremely important.
Yes, I totally agree with you.
So, is there any question, comment, objection? No, no.
There's one from the chat.
Okay, usually when we look at the splenic hemangioma, the standard protocol with 3 or with 4 contrastographic phase is enough because the hemangioma has the same behavior of liver hemangioma with progressive filling. So I think that 3 phases are enough in most of cases, but if you want to become more confident, you can perform also the delayed phase, like in liver parenchyma.
Okay. Any other questions? So, thank you. And we are waiting for the second one.
Okay, thanks.
Thank you.
The artificial intelligence created this image for me. I suggest to do something regarding having both a cystic lesion or liver Thessaloniki in Greece. It creates this for me, so could be useful sometime. Okay, now it's time to show you, to start with another presentation that is dedicated a specific disease that involves a liver represented by ductal plate malformation. The ductal plate malformation represents a complex spectrum of pathological abnormalities that can exist as individual entities or in combination between them. And even if are rare condition, they can be encountered during general examination in everyday clinical practice. And so we should know them because they manifest like a cystic lesion. But first, we should understand the development of the bile duct that usually start during the 6th week of pregnancy, and the bile duct epithelium developed from hepatoblast near portal vein branches. This newborn cholangiocyte create a double layer cuff around the portal vein structures, a portal vein branch, and this is called ductal plate. Moreover, the ductal plate originate from the hilum to the periphery, and the surplus of the bile duct are degraded or absorbed till the 2-8 embryonic week. Then the intrahepatic biliary duct system is immature at birth, and we observe the development of smaller ramification during the first neonatal weeks. But unfortunately, in some cases, the incomplete or insufficient remodeling with development of tiny structures may lead the development of malformation, and the remodeling of the biliary tract may affect each part of the biliary tract. That means intrahepatic and extrahepatic biliary tract. And we should know these entities because in most of cases, the ductal plate malformation manifests itself like cystic lesion. As already said, may involve intrahepatic and extrahepatic. In order to be more precise, usually the intrahepatic bile ducts involvement derive from ductal plate malformation and include Caroli disease, von Meyenburg complex, or congenital hepatic fibrosis, while the extrahepatic bile duct involvement usually correspond to the so-called choledocical cyst, which may be secondary to anomalies like the pancreatico-biliary junction. So in one case, you are in front of bile duct malformation. In the other case is a malformation between pancreas and a biliary tract. And according to the duct size affected, we can observe a different kind of pathological malformation, a different layer. Starting from the bottom, we have the choledocical cyst in the extrahepatic duct. Moving up in the first layer, we should have the Caroli disease. Intermediate level, we have the polycystic liver disease, and while in the distal tract, in the distal layer, we could be in front to biliary hamartomatosis or congenital hepatic fibrosis. But how can we study these different entities? We can take the advantage of different technology in radiology world, represented by first ultrasound examination, that is the first line imaging, the typical one that we use in patients with biliary disease like stones or just for screening, but unfortunately it has low sensitivity and specificity, while the contrast enhanced CT scan should be considered the first choice to evaluate both the liver parenchyma and biliary tree, while the MR with cholangiopancreatographic sequences should be considered as the reference standard because it highlights the fluid content lesion and increase our specificity in making the correct diagnosis. So the ultrasound is very simple to manage. We have the availability in all of the hospital, offer a real-time visualization, so it's fundamental for initial assessment of liver lesion. It allows a full liver evaluation and could be performed also at the bedside of patient. And by using the Doppler, we can also recognize the portal vein patency, and also the application of contrast agent may increase the detection of focal liver lesion, and most important, the communication of cystic liver lesion with the biliary tree. While the contrast enhanced CT scan represent one of the most important techniques because allow us through the different acquisition protocol that we already saw, the different characteristic of the incidental cystic lesion. Because with an enhanced CT scan, we can recognize the pure liquid component or the hemorrhage or hemorrhage component. During the arterial phase, we can recognize the typical peripheral enhancement of abscess and so infected cystic lesion. While in portal venous phase, we can differentiate immediately the cystic component from normal liver parenchyma. And finally, in the delayed phase, we can recognize the typical fibrotic alteration of periportal region. Finally, MR is the most important technique to diagnose the biliary tree disease, the fluid content liver lesion, and to recognize them. It is a non-invasive technique with a very high detailed images. It is really useful because it's non-invasive. Do not expose patient to the radiation. It means that we can follow up this kind of lesion along the entire life of the patient. We can obtain an entire evaluation of the biliary tree and provide information of the liver parenchyma as well. And for this reason, we should build our protocol in the most correct way in order to highlight all of the information that we need from our study. And we should use also hepatospecific contrast agent in order to derive vascular and functional information at once. So at the beginning, we need the T1 sequences in phase and out of phase, and the T1 sequences are mandatory and really fundamental to recognize the anatomy of the liver, to evaluate the shape of the liver and the differentiation between fat accumulation or fat-containing lesion inside the liver parenchyma or the pure fluid content lesion. Moreover, the T1 sequences are really useful also for differentiate the pneumobilia that is hypoattenuating from the stones because they have different morphology and different behavior. In one case, we can recognize a linear hypoattenuating alteration in line with pneumobilia, while if we have only rounding focal hypointense alteration, we are in line with the stones. T2-weighted sequences are mandatory, again, to recognize the anatomy of the organs, but most important, to correctly highlight the different focal liver lesion according to the different hyperintensity on the T2-weighted sequences. Moreover, the T2-weighted, since highlight the fluid content, are really useful also in case of phlogistic phenomenon, because we can appreciate the edema of liver parenchyma, edema of periportal space, and we are able, again, also to recognize the stones inside the gallbladder or inside the biliary tree. In the same way, the diffusion-weighted sequences may highlight the presence of any possible kind of focal liver lesion, but are also able to recognize fibrotic and inflammatory condition. But the mandatory and most important sequences when we look at the cystic lesion and when we look at the biliary tree are represented by the cholangiopancreatographic sequences because allow us to delete the signal of the different organs and highlighting only the fluid inside liver parenchyma. Finally, we can use also the contrast agent, again with a different contrast phase, an enhanced arterial phase, portal venous phase, and delayed phase, in order to analyze the vascularization of the liver, to recognize any possible focal liver lesion, and to recognize any phlogistic phenomenon. But from a clinical point of view, in our case, we suggest to use, when we have to study the liver, to use the hepatobiliary contrast agent, because it has a biphasic behavior. In the first phase, we have the typical interstitial distribution, so we can observe an enhanced arterial, portal venous, and delayed phase, but we can take the advantage of functional information after 20 minutes after the intravenous administration, because the hepatobiliary agent is able to go inside the liver cell, and so it is really able to recognize the unhealthy liver or those lesions that does not contain liver cell, like metastasis or neoplastic condition with high grade of dysplasia, like the HCC or cholangiocarcinoma. So does not function liver cell manifest itself as a black area, but is also important in case of phlogistic phenomenon, because we are able to recognize during the hepatospecific phase the triangular or irregular hypoattenuating area in line with fibrosis or with phlogosis. Moreover, the hepatobiliary phase has another added value, because it is able to evaluate the excretion of the biliary contrast agent along the biliary tree, because they use the same bile duct canaliculus along the liver cell, so they are mandatory to evaluate the biliary tree before any surgical procedure, and again can be useful in some patients with fibrotic liver condition in which the biliary tree may do not work. And I would like to show you this example of two different patients, both of them with primary sclerosing cholangitis. In this case, we are in front of typical cirrhotic evolution. And during the hepatospecific phase, we can recognize this huge hypoattenuating area in line with fibrotic area characterized also by retraction of liver capsule. While in this case, we are observing dilation of the left and the right biliary tree, but in one case, in the right side, we have the correct excretion of the contrast agent, while in the left side, we do not have any biliary excretion. It means that our endoscopist or our interventional radiologist should treat this stenosis in order to relieve the liver function. And obviously, coronal plane can be really useful in hepatospecific phase to better delineate the anatomy, the fibrotic condition, and the excretion of contrast agent as well. So this could be a possible acquisition protocol that we use in our clinical practice. In only 20 minutes, we are able to derive all of the information that I have described before. And now it's time to decide what we have to look at in patients with ductal plate malformation. We have to look at the biliary tree, we have to look at the liver, but we have to look also to other important organs, pancreas and kidney, because in most of the cases, the cystic lesion may involve also pancreas and kidneys, and so we can increase our confidence in making the correct diagnosis. But let's start with biliary tree. First, we should look at the standard anatomy of the biliary tree, remembering that in some cases we can be in front to several malformations or anomaly, and the most frequent one is represented by the crossover anomaly, in which the right hepatic biliary tract drain in the left biliary tree. And the other really frequent malformation of biliary tree is represented by the trifurcation, in which we have the left biliary duct and we have two right biliary duct, one for the upper lobe and the other one for the lower lobe. And again, it is important when we look at the anatomy of the biliary tree, maybe to use the hepatobiliary contrast agent, because the contrast agent in hepatobiliary phase present a higher signal to noise ratio, and so it increases the attenuation of bile duct, especially when the bile ducts are not dilated. If we use this contrast agent, we can recognize the tiny malformation, like in this case of patient that present a trifurcation that was not so evident using only the cholangiographic sequences due to the abnormal appearance without any dilation. Moreover, we should measure the caliber of the common bile duct that usually should not exceed 8 millimeters. We should measure the left and the right bile duct that should not exceed 2 millimeters. We should look at the regular appearance of the peripheral bile duct, and we should look also at the morphology, shape, and margin of the bile duct, and we should recognize and highlight any possible presence of stenosis or biliary dilation to make the correct diagnosis. When we look at the liver, again, we should look at the anatomy, and usually we use the hepatic vein and portal vein to correctly localize each segment using the Coyneau segmentation. We should look at the morphology, knowing that the right liver lobe is bigger than left liver lobe, except in those cases of cirrhotic and fibrotic evolution, like in this case. We should look at the margins of the liver, because should it be linear. In case of irregular margin, again, we are in front of fibrotic and cirrhotic evolution. We should recognize the presence of fibrosis and edema that can manifest itself like hyper intensity area with a linear appearance or huge wedge shape alteration. We should measure the portal vein caliber that should not exceed 12 millimeters. In case of, again, of cirrhotic evolution, we are in front to hypertension with increase of caliber of portal vein. And we should look at the enhancement pattern of the entire liver, evaluating also the hepatobiliary phase, and the enhancement can be useful also to characterize and recognize any possible focal liver lesion. Finally, as already said, do not forget to look at the kidney and pancreas, because, for example, in case of polycystosis, we can recognize several cystic lesions in pancreas and kidney as well, or in Caroli disease, we have the typical medullary sponge kidney evolution. So let's start describing now the ductal plate malformation, starting from extrahepatic bile duct. And as already I said, the choledocical cyst represents the typical cystic malformation of extrahepatic bile duct. But only in this case, we are not in front of ductal plate malformation. When we talk about choledocical cyst, we talk about the dilation of mainly extrahepatic biliary duct, but we could have also intrahepatic biliary duct. As already said, some authors believe that these entities derive from anomalous junction with pancreatic and common bile duct. We can observe several cystic or biliary dilation that can reach also 10 centimeters in diameters. Typically are diagnosed in the first years of life, and in most of the cases, the patient are symptomatic only during the inflammation. Most important thing, we have a classification of the choledocical cyst according to Todani classification, in which the type 1 is the typical fusiform dilation of the common bile duct. The type 2 is the typical diverticulum of the bile duct. In case of the type 3, we are in front of cystic lesion that grow inside the duodenum, so it's a cystic alteration of the papilla area, while in case of type 4, we can have a cystic alteration that can involve in intrahepatic and extrahepatic bile duct, or only the extrahepatic bile duct. Finally, the type 5 of the Todani classification is represented by Caroli disease that I'll show you later. And these are the typical manifestation of the choledocical cyst. If we do an ultrasound examination, we can recognize the cystic dilation of the extrahepatic bile duct, and obviously the anechoic fluid alteration must be part and in communication with biliary tree. In the same way, when we perform the CT scan, we are able to recognize the cystic dilation of the common bile duct, but for sure, the MR with cholangiopancreatographic sequences has the best delineation of anatomy and allow us to better recognize the relationship between dilation and biliary tract. And these are some examples from our series, patient with type 1 choledocical cyst, that is only a dilation of extrahepatic bile duct. In this case, we are observing a huge diverticulum of extrahepatic bile duct that is characterized during the hepatobiliary phase by filling of contrast agent. And finally, here we are observing a type 3 choledocical cyst with a cystic alteration inside the duodenum. And the typical differential diagnosis can be done with hepatic cyst, with enteric cyst duplication, or with pancreatic pseudocyst. Let's move to the first layer of intrahepatic biliary duct. And so now we have to talk about Caroli disease or type 4 of Dani classification. This is an autosomal recessive disorder that is due to a ductal plate malformation, usually is associated with polycystic kidney disease or with medullary sponge kidney. And typically, the Caroli disease is characterized by dilation of intrahepatic bile duct that can be really large and circular or can be both linear, but in most of the cases we have only a segmental distribution, while more rare we have a diffuse form. The most typical sign to make the diagnosis of Caroli disease is the so-called dot sign. The central dot sign corresponds to portal vein branch that is surrounded by hypoattenuating or hyperintense alteration according to the different technique that correspond to biliary tree. So we have the portal vein that is white, that is surrounded by cystic lesion. And usually we can differentiate two different forms, the pure form in which we have only the fusiform dilation, or we could have also the Caroli syndrome, that is a complication of Caroli disease, in which we have also the congenital hepatic fibrosis, and it involves the entire liver. And let me show some examples with ultrasound, in which we have typical anechoic fusiform dilation of the biliary tree, and obviously it is mandatory to recognize the relationship between anechoic cystic lesion and biliary tree. As for sure, the CT scan is the most useful technique to make the correct diagnosis, because it allows us to recognize not only the cystic fluid alteration, the relationship with biliary tree, but especially the dot sign, that is this hyper-attenuating hyper-enhancement of the portal vein branch. And obviously, if we perform the MR, again, we can simplify the recognition between the relationship of biliary tree and fusiform dilation of anechoic structures. Do not forget that since we have a biliary stasis, this patient may develop some stones inside the cystic lesion. They are quite typical in Caroli disease. And again, the most important thing is to recognize the clear communication with biliary tree, and if we use the contrast agent, we can recognize the typical dot sign. This is a special case from our series. In our center, for a long time period, we followed up this patient, and we defined this patient as one with Caroli disease, because we were able to recognize this multiple cyst that seems in relationship with the biliary tree using the cholangiopancreatographic sequences. But unfortunately, only later, in the last few years, by using an hepatobiliary contrast agent, we realized that the cystic lesions are not in communication with the biliary tree. So we are in front of patient with peribiliary cyst and not Caroli disease. So again, for me today, it is important to use this biphasic contrast agent to increase our specificity in making the correct diagnosis. And the typical differential diagnosis of Caroli disease is represented by the sclerosing cholangitis that can be both primitive sclerosing cholangitis or secondary sclerosing cholangitis. In this case, we have stenosis, dilation, fibrotic evolution, peribiliary enhancement that is not typical for Caroli disease, and we have hypertension and splenomegaly. Moving to the intermediate layer of intrahepatic biliary cystic lesion, we have to talk about autosomic polycystic liver disease. In this condition, that is due to ductal plate malformation, we are able to recognize multiple cystic lesions that may involve both the right and liver lobe. The dimension of the cyst can vary from very few millimeters to really huge, 5 or 10 centimeters in diameter. And so when we perform the ultrasound examination, we can recognize multiple rounding alterations with different caliper in size that involve the entire liver. And again, I think that CT is the most useful technique to recognize this entity, because in some cases, this cyst can be characterized by blood inside, and so the unenhanced CT scan is mandatory to recognize the hemorrhage. Moreover, this patient can undergo infection of cystic lesion, and so it is mandatory to administer the contrast agent and recognizing the phlogistic phenomenon. But in the same way, also the MR, it is really useful, even if it is more expensive, but allow us again to recognize multiple cystic lesions that may involve the right and the left liver lobe, different dimension and size. We could be able with an enhanced T1 sequences to recognize the blood content inside infection as well. And please do not forget to look also at the kidneys, because usually this patient presents also cystic alteration in kidney and in pancreas. And the typical differential diagnosis is represented by hydatid cyst. In this case, you are in front of alveolar echinococcosis with biliary hamartomatosis, but in case of biliary hamartomatosis, the cysts are really, really small or with simple cyst. And let's move to the last layer of intrahepatic biliary tree. And so we have to talk about biliary hamartomatosis. That again is a quite frequent condition that we highlight as incidental findings during our examination, both with CT and with MR. It is a ductal plate malformation that is characterized by the presence of multiple tiny cystic alterations that involve both of the liver. And the most important thing is that these microcystic appearances are not in communication with the bile duct. And this syndrome and this biliary hamartomatosis is called also von Meyenburg disease, because it was the first one that highlighted this entity. The lesion never reached a dimension more than 1.5 centimeters. And this phenomenon, this malformation, is due to a block of the final step of the ductal plate formation and are distributed to entire liver. Unfortunately, when the cysts are really small, if we do the ultrasound examination, the cysts are not anechoic or hypoechoic, but they can be hyperechoic. And so we have to do a differential diagnosis with the liver angiomatosis. And for this reason, again, I think that CT scan is the most useful and the most simple technique to recognize the most cystic tiny lesion along the entire liver. If we use the MR, we have a typical appearance that is called starry sky appearance, because we have several microcystic alterations that involve the entire liver, and so can be really evident. And again, the MR can be really useful to highlight the absence of communication with the biliary tree. Typically, the cysts are hyperintense on T2 and hyperintense on T1. And which are the typical differential diagnoses? Are represented by liver metastasis, especially in patients with pancreas adenocarcinoma, like in this case of our experiences, the patient has a lot of microcystic abscess, or typically with breast cancer. Another important differential diagnosis are the liver abscess, especially when they are really small, or again, the simple cyst. Finally, we have the congenital hepatic fibrosis that is characterized by no proliferation of interlobular bile duct with fibrotic deposition in the periportal vein space. That means that the patient develops a portal hypertension. But usually, the congenital hepatic fibrosis is part of other abnormalities like the biliary hamartomatosis or Caroli disease. They grow up together. And the typical signs of hepatic fibrosis are represented by splenomegaly, hypertension of the portal vein, presence of hypertrophic vascular structures, and we have to rule out other associated diseases like the Caroli disease. Finally, when we talk about the cystic lesion, please, we should not forget that these patients are at risk to develop several complications. Typically, for all of the different entities, we have phlogistic phenomenon, so we can have cholangitis in all of the cases or infection of the cyst. And unfortunately, these patients are at risk to develop cholangiocarcinoma. So they deserve several follow-up that could be performed both with CT or with MR using hepatospecific contrast agent. And do not forget, unfortunately, inside the liver parenchyma, we have several cystic alterations that start from a simple hepatic cyst to Caroli disease, biliary hamartomatosis, but we have also infective alteration like the echinococcosis. We can be in front also biliary cystoadenoma, or another entity is called EPNNB, that it is the same entities of IPMN of the pancreas. So that means that we have a papillary tumor of the bile duct that can mimic the ductal plate malformation. So again, even if the cystic lesion seems a really simple condition, can be really complicated to manage from clinical point of view. And so again, it is mandatory to follow up along the history of patient. How can we do the correct diagnosis, or how can we perform the correct differential diagnosis? First, we should count the number of cysts. If we have one or two, and the cysts have the typical appearance without any complication, we are in front of simple cyst. If the single cysts are characterized by hyperenhancement of the periphery, or the patient has a septic shock, septic condition, we can think about infected cyst, hydatid cyst, abscess, or echinococcosis. If the cyst is one and the patient is woman, please think about mucinous tumor. While if the cyst presents a solid component, we should think about metastatic cyst. Moreover, if the cyst is hyperintense on TT1 weighted sequences or is hyper attenuating on computed tomography scan, we know that it could be an hemorrhagic cyst, and so it is a benign condition. And finally, if we have a communication of the solitary cyst with the bile duct, we should think about the intraductal neoplasm. While if we are in front of multiple cystic lesion, we can consider the ductal plate malformation. So if the cysts are in the periportal space, we are in front of peribiliary cyst, benign condition. If the cysts are multiple and diffuse with typical starry sky appearance, we are in front of biliary hamartomatosis. If we have multiple cysts in multiple organs, please consider the polycystic disease. If we have the central dot sign, it is really specific of Caroli disease. And finally, if we have multiple cysts with homogeneous enhancement with some solid component, please think about cystic metastasis. So before to write the report, we have to look at the biliary tree and looking anatomy, malformation, stones, and enhancement. We have to do the same with the gallbladder. We have to look at the liver and analyze the anatomy, morphology, and contrast enhancement. But we have also to analyze in all of the cases pancreas and kidneys to make the correct diagnosis and rule out the less frequent disease. And again, I would like to thank you for the kind attention.
Thank you very much. Thank you. It was very comprehensive. However, the full topic, your analysis was really, really spectacular. And the cases you saw really nice. And this is not a topic that we're familiar with because it's not a common topic in congresses.
Yeah.
But thank you for underlining the clinical significance of the course of the differential diagnosis and the analysis you made on differential.
This is not really common, but in some cases they are not cis. So we have to think about that and follow up that. Yeah.
Thank you very much. Any questions? Any comments? Anybody?
I agree with you. Sometimes because this is a thing which, although see what exists, nobody pays attention if it would be something else. So we should all be alert of this kind of figures. And also in the local cyst category, it's very important to be correctly diagnosed because they might need surgery or interventional procedure, especially cases where patients used to be operated. Usually, a polygonal cyst can be operated in China, and then it reoccurs after 30 years. Suddenly, we see a patient, young patient with a very large cyst and a hydro, perhaps. And if you don't ask carefully, you will never know that she was operated for something, perhaps that they don't know anymore. They were very young. And these relapses, they can be very dangerous for the liver and cause problems. And it's a rare but a very important entity. And of course, from my work, it might be even more rare vision, but it can happen. So, Caroline's disease also. You will find it someday in your practice. It will appear. It's rare, but it will appear. Everybody who is old enough has seen cases. And this is really a very, very comprehensive tutorial overview of all these entities. It's very important. Thank you for having this video in our database.
But I would say that they are not a rare condition. We define as rare condition, but the main down is really common for us, or also the other kind of cystic alteration. If you don't know the disease, you do not use the correct name, and maybe you underestimate the problem. Now, making a lot of MR study, we are just learning day by day how are frequent and how are maybe dangerous, or if they deserve a follow-up.
I'm not so sure that I really don't know how we can, speaking of myself, how can we identify that from my work has no communication in MRCP, for example, it's really very, very difficult to see little very good scanner. Usually they used to say it's a very feral carousel. Just another end.
Yeah. You need also a good protocol, not the scanner. If you are a good driver, you can set on the best machine, and maybe you can obtain also the same kind of results of a high level scan. So in any case, we need time to spend in the scanner and working with the clinician and with the developer.
Because the important thing is not to see something, the important thing is to diagnose it.
Also.
You are able to diagnose it with something that
Yes.
not able to diagnose something that
Yes. Don't know. I totally agree with you.
it's very, very comprehensive topic. Global. I enjoy it.
Thank you.
And your way of presenting it is also really nice. Enjoy it.
Thanks.
I remember as a student, they used to tell us that I never saw it again in my practice. that polycystic liver, pancreatic, and kidney disease is called the Potter syndrome. But I never saw it like it was in my German book when I studied, but I never saw it again in the literature.
Yeah, with the von Hippel-Lindau syndrome, it's not common, but we have some
Okay.
cases. Von Hippel-Lindau. But
This
it's
is
more or less the same things with cystic alteration in kidney, pancreas, and liver. 1/3 year, every 2 years, you can see one patient who has this condition. But they still exist.
okay, but it's not called Potter. So,
No, very common.
Potter.
Any other question? No.
Sorry for.
Thank you very much. Once again.
Thanks. Thank you.